from the pinna to the inner ear one by one. So let's take up number one, pinna. Now, as far as the development of pinna is concerned, before we discuss the development, let me introduce you to this concept that, this is tragus. This is tragus. Okay, this is tragus. And this is the rest of pinna. This is rest of pinna. And both of them are developmentally different. So tragus, write down, tragus develop from first branchial arch. I hope you remember from embryology, branchial arches. Tragus develop from first branchial arch. Okay, and rest of pinna develop from second branchial arch. Rest of pinna develop from second branchial arch. Am I clear about this? The tragus develop from first branchial arch and rest of pinna develop from second branchial arch. Okay, so they are developmentally different. However, let me clarify at the outset, tragus is very much a part of pinna only. So don't think it's tragus separate from pinna. But yes, the pinna has two development. Tragus develop from first branchial arch and rest of pinna develop from second branchial arch. Okay, I hope you remember the concept of the embryology about the branchial arches. This is a picture you must have seen in the embryology book. So these are the branchial arches on the head and neck of the early stage of the fetal development. Okay, so first arch and second arch. So whole of ear actually, let me tell you here only to sum up, whole of ear develop from first and second branchial arch only. Am I clear? Now, let's go to the same diagram once again and understand, because now we are saying that tragus is developing from first branchial arch, rest of pinna developing from second branchial arch. So there must be a line of union of first and second branchial arch. Am I clear? There must be a line of union between the first and the second branchial arch. Now, I think you can guess over here. This is the first arch derivative. Okay. Now, and this is the second arch derivative. Am I clear? Okay. So let me tell you, there is a line here, imaginary line. This line is actually the line of union of first and second arch. This line is called, right now, this is called incisura terminalis. What is the name? Incisura terminalis. Incisura terminalis, right now, it is junction of first arch and second arch. So what is incisura terminalis? It is junction of first arch and second arch. Okay. Now, it has got a clinical importance, right now. It has no cartilage. It has no cartilage. There is no cartilage in this area called incisura terminalis. It has no cartilage. Okay. So there is a surgical significance of that. Right now, therefore, Lempert's end oral incision, spelling Lempert, L-E-M-P-E-R-T. Lempert's end oral incision passes through it. Therefore, Lempert's end oral incision passes through incisura terminalis. Therefore, Lempert's end oral, end money in front of, oral money pinna. Therefore, Lempert's end oral incision passes through what? Passes through incisura terminalis. Therefore, Lempert's end oral incision passes through it. If you see this one, okay, imagine this is your patient, you're operating the patient and you are now going to give Lempert's end oral incision. So this is the Lempert end oral incision. It starts from here, you start from here, okay, and then you pass through which area? You're passing through the incisura terminalis, okay, because there is no cartilage, so there will be no damage to cartilage over there, and after that you go inside the sonotary canal over there, okay. So this is the Lempert's end oral incision. Can you see that, beta? Can you identify the image? End means in front of, oral means pinna. There, fine. This is surgical significance of incisura terminalis. Now, next again a clinical thing. Right now, if the union of first arch and second arch is incomplete, if the union of first arch and second arch is incomplete, it will lead to a congenital disorder. It will lead to a congenital disorder called preauricular sinus. Preauricular sinus. Okay. I repeat that if this union of first arch and second arch is incomplete, it will lead to a congenital disorder called a preauricular sinus. Preauricular sinus. Can you see the black arrow over here? There will be a hole in front of pinna. Parents will come to the clinic and they'll say, doctor, I have a hole in front of pinna in my child. Actually, they'll tell you the child is having a hole in front of pinna. Now, please understand what happened in this patient is that this is the first arch derivative and this hole is second arch derivative. Am I clear? The two arches did not unite properly. So there is not just an opening. If you just open up, you'll see there's a complete sinus tract over there. Sinus is a skin line tract actually. If you surgically open it, you'll find a complete tract. But on the surface, you just see what? You just see a hole like that. You just see a hole like that. Okay? So what's the name of disorder? Preauricular sinus. Now, right now, if asymptomatic, it needs no treatment. Right now, if asymptomatic, it needs no treatment at all. You can leave it like that. If asymptomatic, it needs no treatment. Okay, but if recurrent infection is there, look at this, if the sinus, can you see the sinus tract got infected? Please see over here. This is the place in which the sinus actually has got infected. If recurrent infection is there, then what do you do to the sinus? Then surgical excision of the sinus tract is done. Then surgical excision of the sinus tract is done. Please see on the screen. We just open it up and we remove the whole sinus tract from there. Okay. So if it is asymptomatic preauricular sinus, it needs no treatment. But if it is a recurrently infected preauricular sinus, then the treatment is mandatory in the form of surgical excision of the sinus tract. So this is about the preauricular sinus, which is a congenital disorder due to non-fusion of first and second arch derivatives forming the pinna. Am I clear? And Now let's go further. Now write down pinna development completes by. Pinna development completes by 20th week of embryological life. This is the 4D ultrasound. Can you see over here, beta? Can you see the pinna is over here? Pinna development completes by 20th week of embryological life. We can see very clearly the pinna in the 4D ultrasound. So this is a question. Pinna development completes by 20th week of embryological life. Am I clear? Now let's go further. Does pinna suddenly erupt like this? Can you imagine? Oh, today 20th week got completed and suddenly pinna came out like this, stuck like that, out of the fetus. No, it's not like that. First 6 elevation form on the head of the embryo. They fuse to form the final shape of the pinna. Please understand. First, what will happen? First, over here, 6 elevation will form. Okay, 6 elevation will form, and then they will fuse to form the final shape of pinna. You understand? So first 6 elevation will form over there, and these elevation are called hillocks of His. Right down. Hillocks of His. Hillocks means small hills. Hillocks of His are 6 in number. They are 6 in number. They fuse to form pinna. Please understand. The pinna development completes by 20th week. It's not like that today 20th week got completed in the morning and suddenly the pinna comes out of the human fetus. Not like that. First 6 elevation form on the head of the fetus, and those elevation fuse to form the final shape of pinna. And those 6 elevation are called hillocks of His. So I hope you know. So hillocks of His, once again, they are 6 in number. This is a multiple choice question also, and they fuse to form pinna. Fuse to form pinna. Okay. Now, sometimes the pinna will be totally absent. Okay, write down. What is the name of the disease? Write down. That is called anotia. A-N-O-T-I-A. Anotia is absence of pinna. Anotia is absence of pinna. Total pinna is absent. Anotia is absence of pinna. I think you can see over there that there is no pinna formed at all. Okay, anotia is absence of pinna. Okay, there is another possibility called microtia. Microtia. In name shows that microtia means small pinna. Microtia means small pinna. Small pinna. I think you're very clear. There's a very small pinna over there. Microtia means small pinna. Anotia means absence of pinna. Microtia, small pinna. Anotia, absence of pinna. Okay, fine. Now, next concept now. This is important. Okay, what is that? Write down. Normal pinna has 2 curvatures. Normal pinna has 2 curvatures called helix and anti-helix. Normal pinna has 2 curvatures called helix and anti-helix. Anti-helix. Helix and anti-helix. How to understand helix and anti-helix? Please see, helix is a capital C and anti-helix is small c. Just draw capital C in front of helix and small c is anti-helix. Small c is anti-helix. Everybody look at screen, beta. This is capital C, beta. This is helix. Okay? And this is small c called anti-helix. Okay? Everybody, you can look at my pinna also. You can look at my pinna or you can use your pinna also in the mirror. There's a capital C called helix. There's a small c called anti-helix. So our pinna has 2 curvatures. The outer curvature, the bigger outer curvature is called helix, and the smaller one, the smaller one is called the anti. This is anti-helix curvature. Beta. Anti means in front of. Okay? So bigger c is helix, smaller c is anti-helix. Beta. Now put an arrow. If anti-helix is absent, cosmetic problem, congenital problem. Okay? If anti-helix is absent, the disease is called. It's a disease of cosmetic tissue, you know. Remember, if anti-helix is absent, it's a disease called bad ear. It's a disease called bad ear. Bad ear. If anti-helix is absent, it's a disease called bad ear. Bad ear. Look at screen. Can you see, beta? The bad pinna only has a helix. There is no anti-helix, beta. Okay, this is suiting her, but this will not suit our children. This will not suit our children. You know what? They will look like aliens. You know, they will look like, Amir Khan from that movie, like that. Okay. So what is bad ear? It's a cosmetic problem. It's a disease. It is since birth. It is due to error of development actually. If anti-helix is absent, it is called bad ear. Beta. Let me show you bad ear. Can you see over here? Beta? Please see in the screen. Can you see over here? In this picture, you can see very clearly. This is helix, clear. But there's no anti-helix over there. So this disease is called bad ear. It is not a functional problem, only a cosmetic problem. But parents may be very much concerned about the shape of the pinna. So what is bad ear? Simple answer: absent anti-helix. Now, the plastic surgery of pinna is called otoplasty. The plastic surgery of pinna is called otoplasty. Okay, otoplasty. Okay, it is done at the age of 6 years. It is done at the age of 6 years. It's a multiple choice question. This is a multiple. What is the ideal age of surgery? Look at the child. Child is grown up. The child is grown up. Okay, what is the ideal age of otoplasty? The otoplasty is done at 6 years of age. Am I clear? So what is otoplasty? The plastic reconstruction of pinna is called otoplasty, and it is done at 6 years of age. Am I clear? Wonderful. Okay. Now let's discuss here. There are certain other abnormalities of the shape of the pinna also. Write down other abnormalities of shape of pinna, which are since birth again. Other abnormalities of the shape of pinna. Other abnormalities of shape of pinna since birth. Congenital. Again, congenital is number one. Again, number one. It is called Waldemann's ear. Waldemann's ear. Waldemann's ear is, right now, it is reverse of bad ear. Waldemann's ear is reverse of bad ear. It is absent helix. Can you see it displaced? The helix is actually, helix should be a curved thing. Look at this, this should be a folded thing. It gets unfolded. Absent? Absent means right? Absent means flat. It should be a folded one. Huh? And in this area, you can see, in this area, please see on the screen, here it has got sort of unfolded. Flat means unfolded. It should be a folded one. You can see over there. Your this outer curvature is a little folded one. Folded one. It should not come flat one like that. Look at it. If it will open up like that, okay, that will Wildermuth here. Okay, but again, a cosmetic problem only. It is since birth, and it has to be corrected again at the age of 6 years. So what is Wildermuth here? It's a reverse of the bat here. It is absent. Anti-helix. Absent means it is flat or unfolded kind of helix. Okay. Number 2, other deformity of the shape of the pinna since birth is called Mozart ear. M-O-Z-A-R-T. M-O-Z-A-R-T. Mozart ear. Mozart ear is the second other abnormality of shape of pinna. It is fusion of helix and antihelix. Mozart was a very famous musician from Austria, and probably it is on his name. He used to have very long hair, probably to cover his shape of the pinna, which was not good. So Mozart name came from the Mozart, which is a very famous symphony musician of Austria, I guess. So it is actually fusion of helix and antihelix. Sorry, fusion of helix and antihelix. So they get fused and they become parallel lines, very similar, very like this, very parallel line kind of thing. Mozart ear. Fusion of helix and antihelix is called Mozart ear. So let's quickly revise. There are 3 abnormalities of the shape of pinna. The most common one is bat ear, and bat ear means absence of antihelix. Wildermuth ear is absence of helix, means flat or unfolded one. And last one, very rare one, Mozart ear, it's a fusion of helix and antihelix. All these are cosmetic problems of pinna. They are since birth. They don't have any functional problem, but the plastic surgery would be required if parents are concerned, and that surgery is called otoplasty. And the ideal age of otoplasty is 6 years of age. That is your multiple choice question. Okay, fine. Now, let me go further to the other parts of development. We are doing development of the ear. So now we finish. Now the next one. Now, write down next one. External auditory canal. External auditory canal. We call it EAC later on. EAC. It developed from first branchial cleft. First branchial cleft. I told you, between the 2 arches, first and second arch, outside there is a cleft called first branchial cleft. First branchial cleft. Okay? Let me show you the first branchial cleft first of all. First branchial cleft. Let me show you that. First branchial cleft. Now, everybody look at screen. Please see, this is the fetus head and neck area, and these are the branchial arches. Okay, 1, 2, 3, 4 written. Now, this is the first arch, the second arch. The pinna developed from first arch and second arch. Can you see? Look at my finger over here. This cleft, can you see the cleft? This is going between the first arch and second arch. This cleft is called first branchial cleft. If this and this makes the pinna, the first branchial cleft, which is between the first arch and second arch, will definitely form the external auditory canal. Actually, if you recall, the branchial arches, there are 3 layers of branchial arches. Outside, this is outside, the skin side. Outside is ectodermal layer. Towards the pharynx side is the endodermal layer, the mucosa side, and in between ectoderm and endoderm is the mesoderm. So branchial arches are made of 3 layers: outside ectoderm, inside endoderm, and in between the 2 layers is mesoderm. Okay. So when I say outside, it's a skin side. Actually, this side will make the skin ultimately. When I say inside, I mean the endoderm, the cavity side, the pharynx side. The endoderm will form the mucosa inside the lining of the pharyngeal cavity of the head and neck area. Now, the mesoderm is sandwiched between the ectoderm and endoderm. That makes a major bulk of the, these arches over there. Okay. So that's why I'm writing down that the external auditory canal developed from first branchial cleft, and we are now very clear that the pinna is developing from first arch and second arch, and this cleft between the first arch and second arch, this is called the first branchial cleft. This is the site of origin of the external auditory canal. Am I clear? Now, number 2. Next. Number 2 is next development, eustachian tube and middle ear. Write down. Eustachian tube and middle ear. ET, eustachian tube and middle ear. They develop from first branchial pouch. First branchial pouch. So eustachian tube and middle ear is mucosa line. Eustachian tube is towards the pharynx side. Middle ear is mucosa line. So they develop from the pouch side. I told you pouch side means endoderm side. Okay, fine. Now, next one. Number 3, write down. Number 3, tympanic membrane. Tympanic membrane develop from all 3 layers. Tympanic membrane develop from all 3 layers. That is ectoderm, endoderm, and mesoderm. Ectoderm, endoderm, and mesoderm. I told you human embryo develops from 3 layers: ectoderm, outside, endoderm, towards the mucosa side, the pharynx side, and the mesoderm. Sandwich between the ectoderm and endoderm. So the 3 things to remember. Number 1, external auditory canal develop from first branchial cleft. Number 2, eustachian tube middle ear develop from first branchial pouch. Number 3, tympanic membrane develop from all 3 layers. That is ectoderm, endoderm, and mesoderm. Am I clear? Okay. Let me draw a diagram to help you understand this further. Now please see. This is your the branchial arch number 1. This is the branchial arch number 2. Number 1, number 2. Okay. So the yellow thing is ectoderm. This one ectoderm. The ectoderm. This one is endoderm, and here is like a mesoderm. Okay. Outside is all this is outside. Ecto. Inside is endo, and between the 2 is meso. This is the mesoderm. Am I clear? Okay. This is the outer side. This will form the skin. This is the ectoderm is the outer side, of course. Okay. Now this is actually the first branchial cleft. Okay, first branchial cleft. And this one is what? The first branchial pouch. First branchial pouch. Between the two arches, inside the pouch, outside the cleft. Okay, am I clear? Please see on the screen, let me enlarge it for you. Please see beta. Okay, now this is the pharynx side, inside of the body cavity. This is actually toward the pharynx side. This is the skin side. Okay, now what will happen is that from the first branchial cleft will develop the external auditory canal. Okay, and from the first branchial pouch, from the inside, will develop what? Eustachian tube and middle ear. Eustachian tube and middle ear. Eustachian tube and middle ear. Please understand, from outside forms the external auditory canal, from the left side, from inside forms the Eustachian tube and middle ear, and where the handshake happens, everybody look at the screen. There is a place where handshake happens. Please see, where the handshake happens. Where the handshake happens, there becomes the tympanic membrane. Tympanic membrane. You know why? Tympanic membrane develops from all three layers. Ectoderm, right one, out coming from outside. The endoderm, red one, coming from the inside. And between the two is sandwich here is the mesoderm. So this is ectoderm, this is endoderm, and this is sandwich here is the mesoderm. So from outside came the ectoderm of the first branchial cleft. From inside came the endoderm of the first branchial pouch, and got sandwiched between the two was the mesoderm of the arches. And this junction where the two things meet form the tympanic membrane. Okay, so let's revise once again. Let's revise once again this picture. That I hope everybody is clear that the external auditory canal developed from first branchial cleft. Eustachian tube developed from first branchial pouch. Okay, this is the pharynx side, inside of the neck, and the other one is skin side. And where these two meet, the ectoderm and the endoderm meet, this area forms the tympanic membrane. That's why we say tympanic membrane develops from all three layers: ectoderm, endoderm, and mesoderm. Later on, we'll study about tympanic membrane structure. I will tell you, tympanic membrane is made of three things: outside skin, inside mucosa, and middle fibrous layer. Outside skin, ectoderm. Inside mucosa, endoderm. And middle fibrous layer will be formed by the mesoderm actually. So this is so logical. It's so logical. Okay. Now, let's go to the next one now. Right now. Next, development of ossicles. Development of ossicles. Next topic. Development of ossicles. Okay. Write down. Write down. These are three ossicles. These are three ossicles. Okay. Write down. Malleus and incus. Malleus and incus develop from. Malleus and incus develop from first arch. Malleus and incus develop from first arch. Okay. Now, next one. Stapes. Now, this is malleus, this is incus, this is the stapes. Stapes. Now, please see, stapes has two developments. One is the head, other is foot plate. Head and foot plate. Okay. The head develops from second arch. I hope you remember I told you the whole ear developed from first arch and second arch. Pinna developed from first arch and second arch. Ossicle developed from first arch and second arch. Okay, but you know the head of the stapes developed from second arch, but the foot plate of stapes developed from otic capsule. Otic capsule. Foot plate of the stapes developed from otic capsule, which is nothing but neuroectoderm. Which is what? Neuroectoderm. This is nothing but neuroectoderm. Am I clear? Fine. Is okay. The stapes have got dual origin. The head of stapes is developing from second arch. The foot plate of stapes is developing from the otic capsule or neuroectoderm. Okay. All you can draw the stapes over here. This is the head of the stapes. This is the head of the stapes. This is the foot plate of stapes. So you should know the stapes. Very easy to understand. This is called the head of stapes, and this much is called the foot plate. This is called foot plate. So this is the foot plate of stapes. Foot plate. It's a cup. It's like a cup on a plate. It's a cup on a plate. Okay. So foot plate of stapes is different in origin because actually I'll tell you this is developing from otic capsule, which is nothing but neuroectoderm. Okay. Now you can write over here the foot plate of stapes. Put an arrow. Put an arrow. Put an arrow. It is attached. It is attached at oval window of cochlea. It is attached at oval window of cochlea. Foot plate of stapes is attached at oval window of cochlea. I hope you know cochlea is a purely neural structure. Cochlea is neural. Because foot plate is actually attaching to cochlea only, and cochlea is neural in origin. That's why foot plate, which is actually attached to cochlea, is also taking origin from the same structure which is giving origin to the cochlea also. Okay, so foot plate, it is attached at oval window of cochlea, and we know now that cochlea is actually neural. So it is attached where? Please look at screen. Please look at screen. This is your, ossicular arrangement. This is let me mark it for you. This is your malleus. This is your incus. This is your stapes. This one is your stapes. Am I clear? This is the foot plate of stapes. This is what the cochlea. Can you see foot plate of stapes attached at where? At the cochlea only. So I think you can understand that footplate of stapes is actually attached to cochlea. So the origin of the cochlea is same as the origin of the footplate of stapes. So they share the, I would say, the source of origin. So footplate is developing from otic capsule, which is actually neuroaqueduct. So that will tell us the development of cochlea also. Am I clear? Fine. Write down development of cochlea. I will write down development of cochlea. Development of cochlea is from development of cochlea is from development of cochlea is from otic capsule which is actually neuroectodermal. Neuroectoderm. So now I'm clear that footplate of stapes being attached to cochlea shares the origin with the cochlea. So both of them, the footplate of stapes and the cochlea, are originating from one thing called otic capsule, which is nothing but neuroectodermal. Okay, am I clear? Now, one more thing. Cochlea development completes by 20th week. I hope you remember, pinna development completes by 20th week, cochlea development completes by 20th week with them. Okay, so pinna development and cochlea development both complete by 20th week of pregnancy, of embryological life. Okay, now, right down. Inner ear. Let's talk inner ear development a little bit in more detail. Inner ear development. Cochlea is a part of inner ear. Cochlea is not a full inner ear. If you just can recall that this is the the inner ear bit over here. Now this is actually can say this is the cochlea. This one is of course the cochlea here. This is saccule. We read in detail in inner ear topic. Saccule. This is utricle, and these are what semicircular canals. Let me draw up to this is semicircular canal. This is utricle area. This is saccule area. Then the cochlea. So cochlea is a neighbor of saccule. We see this is cochlea. Don't worry, we read it detail in inner ear. This is cochlea. I'm just reading developmental angle. This is cochlea. This is saccule. Cochlea and saccule are neighbor. Then this is utricle and semicircular canal are neighbor. They two are. This is one unit. You can say cochlea and saccule are neighbors, and utricle and semicircular canal are neighbor. Okay. Now let's write from where these two components are developing. Okay. They are two little different components as far as development is concerned also. Now write down the again otic capsule. It forms two things. Pars superior and pars inferior. Pars superior and pars inferior. Pars superior and pars inferior. Am I clear? Now, from pars superior develops the semicircular canals and utricle. Two things, semicircular canal and utricle. From pars inferior develop the cochlea and saccule. I told you cochlea is a neighbor of saccule and semicircular canal are neighbor to utricle. So otic capsule makes two distinct compartments, I would say, the pars superior and pars inferior. So let's see once again, the pars superior, please see, this is the upper part. The pars superior will form the semicircular canal and utricle, and pars inferior will form the cochlea and the saccule. Okay, and please do remember that the development of cochlea finishes by 20th week of embryological life. Now, can you see one more thing, that cochlea has got 2 3/4 turns. Cochlea has got 2 3/4 turns. Okay, and when we discuss the inner ear development, we'll discuss all the detail, the inner ear topic. We'll discuss detailed structure of the cochlea also. Now, I would like to introduce you over here that the inner ear developmental deformities can be understood more properly if you remember one point about it, that cochlea and saccule are neighbor, and utricle and semicircular canal are also neighbors. Okay, fine. Now some of the extra things to be remembered about the development. Okay, now write down next one. Write down one Viva question or multiple choice question. Write down ear structures which are of adult size at birth. Ear structures which are of adult size at birth. Which are the structure of adult size at birth? Number one is middle ear. Number two, ossicles. Number three, cochlea. This can be asked from you in the Viva or the multiple choice question. Which are the structures which do not need to grow after birth? They already attain the adult size at birth only. Answer is middle ear, ossicles, cochlea. These are already of adult size at birth. Okay? Now, one more multiple choice question of embryology related thing. Write down next one. Okay. Mastoid tip. Everybody, all of you palpate behind your pen now. This is a mastoid tip area. Okay, mastoid tip, which muscle attaches to mastoid tip? Sternocleidomastoid. This is sternocleidomastoid. So this tip, mastoid tip on which this muscle is attached. Mastoid tip is absent at birth. So this is a point to remember. This tip is absent at birth with them. It is not there at birth. Absent at birth. Okay? Absent at birth. It develops at 2 years of age. Now, this is a multiple choice question. It develops at 2 years of age. It develops at 2 years of age. 2 years of age. Okay? Fine. Now this has got a significance because it is to be understood that in a very young child, if you're operating a 1-year-old child for ear surgery. Now please understand, when mastoid tip is not there in a 1-year-old child, then hidden below the mastoid tip is a foramen called stylomastoid foramen. Stylomastoid foramen is the exit point of the facial nerve out of skull. So when there is no mastoid tip, it means that facial nerve is lying very superficial. Please understand, the mastoid tip is a cover of the facial nerve exit area. What is the exit area of the facial nerve from skull? That exit point is called stylomastoid foramen. When mastoid tip is not there, it means facial nerve lies very superficial in a very young child, which is below 2 years of age. Okay, put an arrow. Therefore, in children below 2 years of age, in children below 2 years of age, the facial nerve lies very superficial. The facial nerve lies very superficial. Okay. Therefore, during ear surgery, in patients of this age group, during ear surgery in patients of this age group, the conventional post-oral incision should be avoided. Therefore, in patients of this age group which are below 2 years, conventional post-oral incision should be avoided. Okay, why? Look at me, brother. What is post-oral incision? Post-oral means behind the pinna. When you start from the upper end of pinna, you go till the lower end of pinna. All of you palpate behind your pinna. The lower part of pinna is nothing but the mastoid area. Now imagine you're operating a child who is below 2 years of age, and you give incision from here, and you go down with a blade knife over here. Now facial nerve is lying very superficial in the mastoid area over there because there is no mastoid tip. So if you give a cut like this from here to here in the conventional way, in a young child also, you might damage the facial nerve. Okay, so please do not give a curvilinear incision like that. Rather than that, give an oblique and horizontal incision. Right now, in its place, horizontal or oblique incision should be given. Therefore, in its place, horizontal or oblique incision should be given. This is the clinical applied anatomy. Because once again, mastoid tip is absent at birth. It takes 2 years to develop the mastoid tip. When there is no mastoid tip, we should understand the stylomastoid foramen, which is actually the exit point of the facial nerve, lies very much superficial. So in case a surgeon is operating on a child who is less than 2 years of age, and you are giving a standard conventional post-oral incision, which is a curvilinear incision right from the upper part of pinna and makes a C and goes up to the mastoid area. So if you make incision like that, you might cut the facial nerve in this young child. To avoid this injury to the facial nerve, we do not give this conventional post-oral incision. Rather than that, we give a horizontal, like look at a horizontal or an oblique incision. A horizontal incision or oblique. Either a horizontal behind the pinna, horizontal incision or oblique incision. And then you open and you operate. So that you're away from this area. Don't come down. Okay? So these were the concepts which are actually required for the embryological development of the various parts of the pinna and the applied anatomy also. Okay?